Okay, good morning, everybody. Thank you for attending and joining us. We're honored to be here. I'm Ryan McCormack, and this is Kathryn Hawk. And today we're going to be talking about access to treatment and research for marginalized populations. And a note, the slides that are currently in the app are incorrect. And so if anybody would like the slides, they can reach us by our email. We're glad to share them. We have no conflicts of interest to disclose. Our funding is listed there. And really what we're talking about, I mean, in the Venn diagram, substance use disorders and health-related social determinants there's a big overlap, and they definitely affect access to research and best evidence-based treatment. And so one of the things I'm asking of you at this point is, when you think about the gold standard randomized controlled trials, they often will exclude marginalized populations, or they end up excluded. And some of the things I'm just wondering is, why do you think that is, and how might excluding or including patient populations that are, or marginalized patient populations, threaten rigor to these studies? Scott, did you have?
Generalizability.
And yes.
And also an attrition.
An attrition, yes.
Yeah,
so you actually answered both questions on this thing. So one of them really, including patient populations, including marginalized patient populations who are at a higher risk of loss to follow-up or attrition, can threaten rigor. And then, as you said, if you exclude marginalized populations, it's not a representative sample. And there are other reasons. And so I think in our slides, as this is just a 20-minute presentation, we were pretty inclusive about some of these factors and want to make them available to you. And so you already mentioned attrition, loss to follow-up. And there are other reasons are just kind of keeping research simple. It can be harder to recruit and retain more challenging or marginalized populations. The complication analyses are more complicated because you have to adjust for the loss of data. And if you have the loss of data, there's definitely a perception of the loss of rigor and quality of the study, which can have its other impacts potentially on publication and funding. And this group, although many are not necessarily technically considered vulnerable, there are concerns about whether risks of coercion, level of compensation, they may have a higher severity of illness. And then also, if for factors that make it harder to adhere to the intervention or, say, medication, if they're unable to adhere to it, then that will dilute the effect size and you would need a larger sample. And then, of course, there's stigma and prejudice that we know exists, and and I'll leave it there. So just to kind of go over some of the terms and what we're talking about here. So selection bias and sampling bias is really just some members of a population are really in a systematic way more likely to be included in the sample and represented in the end. And if we look at how that can occur, there's the population, let's say in this case, the population of emergency department patients, and then the sampling frame. Those who are included in the sample may not be, if it's not representative of the whole population, there's some undercoverage where some members of the population aren't making it into the sample. And then attrition and non-response is later on when patients or participants aren't able to follow up and aren't represented in the results. And so there's also not included in the study in that way. And this is more of a pictorial way of showing it. So in this case, let's say there's 40% of emergency department patient population is homeless, but in your sample you only end up enrolling 10, in the sample that you enroll, only 10% are homeless. And then of that sample, you lose to follow-up 10% of the participants, and of those, half of them are homeless, and so you end up with no homeless people in your population. And so you can see this gives you an example, it's kind of an example of how you can end up losing what we're talking about here. And so one of the questions that you have to ask yourself is, how do we balance these threats when designing studies? And it's really, the key point is, what is your research question? And then designing your study and your methods according to that question, because there are always limitations, and you want to and balance what is most appropriate to answer your question and acknowledge those threats when they occur. So again, design your study according to your question. And a double-blind RCT may not always be appropriate for your best question. We're going to go through a couple of examples to walk through this. And just also, as you mentioned, as you went through with some of those biases, just use caution and acknowledge your limitations. And another thing that I can't stress enough is piloting your study. And so one of the things I'd like to ask you is, well, like, what are some strategies that you could use to support inclusion and retention and to mitigate bias? And feel free to pop in if you have any. Great. So one of the things is, and that's kind of, this one, or there's some general strategies, you're right, like providing compensation, minimizing the number of follow-ups as much as possible, trying to make things brief and flexible, calling people at different times of the day, seeing if it's feasible to do it in person versus a virtual visit, really sending routine reminders. Some of those can be kind of friendly reminders in addition to the scheduling, seeing what their preference is, days and nights, weekends if possible, updating their contact information in different ways. And then if you are, and just plan ahead so that you oversample if you know that there's going to be attrition.
One of the things that we do a lot is you ask if people prefer text or email, in general, or a phone call, and you were surprised that people do not often always want the same thing. So we really try to, when we enroll people in a study, actually collect that information. So otherwise, you can think about outside the box for marginalized populations. So think about overcoming sampling bias at recruitment. When you're thinking about how to enroll people or how to get them in, you can think about, whether you ease enrollment criteria or restrictions. So for example, one of the studies we're doing right now, people have to have multiple contact information, not just your own phone number, but they also have to provide 2 additional contacts. And so it's really trying to balance the ability to be flexible for people that you want to be able to find to complete your enrollment, but also, and to complete your follow-ups, but also realizing there are a lot of reasons why different people might not have as much contact, or they might not have them sort of right there, right then. Also, you can think about facilitating meeting eligibility criteria. So we're going to go through an example sort of later on where, a lot of, particularly when you're looking at marginalized populations in the emergency department, they may not have a phone. They may not have a phone number. They may not have they might have housing instability. And so for one of our studies, we actually, as part of the compensation, actually provided them with a phone and a 30-day plan. You can also think about sort of, I don't know if you want to talk about the mailbox in the city.
Yeah, so I mean, this isn't available in all places, but in New York City, if you can, there's one of the post offices where where they will allow people without an address to use that as their primary address so they can receive mail. And then just other thinking out of the box with other contacts. So if your study requires that you have multiple locators, and it's best if you do, thinking about, like, is there somebody at the shelter? Does this person have a caseworker? And then another thing that, particularly in addiction research, is engaging patients and building trust. There's a lot of distrust, mistrust that occurs. As we've been talking about, it's difficult to navigate health systems and social services, and there's a lot of stigma and prejudice traditionally. And so looking at ways, just being kindness and providing some, and listening to their needs, and maybe providing food or coffee at the time that you're talking to them. And then just incrementally trying to build trust, maybe not ask for the, and then just on the other, so that was like how you bring people into the study equitably. And then also, what are some strategies to keep them in the study and so that we don't have undercoverage? And so some of the things you could do is partner with community agencies. For one of my studies, I partnered with Homeless Services, and so their outreach team, if they would contact somebody, we also worked with EMS, so we would see where their people were picked up. We already mentioned the non-traditional contacts. There's a study that Josh Lee does with the criminal justice where they have a navigator who goes into the community and has lived experience to help find people. And so asking things like particularly in that kind of a model, where does somebody bed down? Where do they cash their checks? Like where might they go? And just really being creative with how you might think about things. You can most EMRs can set up alerts or looking through the notes to see if they've had contact and if updated contact information is there. Seeing if mobility or transportation is an issue. And then also as just really low barrier with flexibility and contacts, meeting people in the lobby, and having a wide time window for when you'll meet them and when you allow the follow-ups for data collection. And then once there is, so part of this is preventing, but also we need to mitigate when there is missing data. So just plan ahead in your methods, again, pilot, and then think about, are there ways that you can evaluate outcomes without, if you do have lost a follow-up or without the participants' involvement. So particularly things like healthcare utilization, there might be other data sets that you can use. Triangulating multiple sources of data, so you've got your self-report, which requires the participant, looking through the EMR. We're going to go through an example of what we've used. And then also frequent data collection. So if you want to see how much they've been drinking in the last period of time, instead of doing it every 3 months, maybe do it weekly, or if somebody misses, try backfill when it's appropriate. And then from the analytics side, there are some strategies that you can do when there are missing data. And so you can first, how do you detect this? You can compare the baseline characteristics to the final sample characteristics to see if they're same or similar. And then doing sensitivity analyses, so if there's missing data, things like last outcome carried forward, initial response, propensity scores to match to see if they're similar between groups. And then again, just triangulating with other sources of data and using historical data. And having a great statistician is key. So just going through a few kind of cases. So just think about how would I design a study if it was a efficacy study? Oh, I already put RCT, but if you wanted to do an efficacy study for ED-initiated buprenorphine, later, kind of a next step might be looking at the implementation on a larger scale and effectiveness. So efficacy is under ideal conditions, effectiveness is the whole population. And then you might want to look at specifically a subpopulation of patients who are more marginalized. And so the first example that I would say is the study at Yale that was led by D'Onofrio, published in JAMA in 2015, was a large RCT to look at the efficacy and feasibility. Well, we'll just keep it simple, say the efficacy of ED-initiated buprenorphine. And so for this study, when we think about how restrictive do we want to be, and so as an efficacy study where we're trying to see under ideal conditions, you really want to have complete data sets. I mean, you always want to have that, but so for this study, although they were able to capture a lot of patients who were experiencing homelessness, like a huge proportion, but it was important. They did have those 2 locators and 2 contact informations and dedicate a lot of resources to make sure that there was no loss to follow-up. And they did sensitivity analyses as well. And then, so when you're then looking, another study that Kate and I, along with several others, the NIDA Clinical Trials Network did, was looking at the feasibility, more of the implementation and effectiveness and a feasibility study in more difficult settings where we're trying to see the whole population. And so in that situation, we want to make sure that it's generalizable to the whole population, that we're capturing the whole, that it's going to be represented, that the sample is truly representative of an emergency department. And so we chose to be a little bit more lenient in how we defined our inclusion-exclusion criteria and implemented some of the strategies that we started discussing on the other slide. And some of those are here. So for that, it was we didn't randomize, because, and part of that was the implementation side. So if you're looking at implementation, we wanted to see in a real-world context, in a naturalistic setting, is this effective if it's delivered by clinicians as opposed to a structured research team doing it. But focusing more on the inclusion of marginalized patients, we reduced the number of contact and locator informations. We made provision of cell phones and service plans as part of the compensation as an option, so that people who didn't have phones could get a phone and be eligible for the study if they participated. We had multiple different sources of data and participant types. So there was a qualitative study where we had patients, providers, and other informants give us information. We looked at patients through the EMR, through a waiver of consent. There were limited and full study participants, some that were not interested in following or couldn't follow it because they lacked ability to meet eligibility criteria. So there's, and then we also had, we had self-reported outcomes, objective measures, the qualitative interviews and focus groups. We looked through the EMR, contacted their referral sites through releases of information, and we used administrative data through the PDMP, and we'll soon have Medicaid claims, so that we can really try and look at where there's missing data, compare the different data sets, and in the same way that you might look at attrition, whether the baseline characteristics are similar to the follow-up characteristics, we can see if the participants in the study are similar to like the claims outcomes. And then most importantly, we have a really detailed limitations section, and you can find it. It was just published online in Annals of Emergency Medicine last week. And our references are at the end of the study. Another thing is just to consider the clinical realm as well. So much of what we just discussed also applies to receiving clinical care. Particularly, this became evident when COVID emerged, that the transition to so much telehealth and virtual health is if people don't have phones or smartphones or health literacy, they can't just walk in for appointments, they can't schedule appointments, they can't have their appointments if they don't have access to those or don't know how to use them. And there also, really importantly, are a lot of often unintended consequences of deliverables and metrics that go with programs. So, for example, if you have a care management program that's implemented, there's going to be metrics and deliverables that they're expected to achieve with like the number of number on the caseload, the number referred, the different outcomes. And so there is an incentive to cherry pick the easiest cases or those with kind of where you don't have to, with a simple intervention. And so there can be systematic or individual ways that you can do that cherry picking. And so, in the past, I remember learning about health insurance companies with their enrollment being on the second floor of a non-ADA facility, so that that would be an example of like intentional cherry picking. And then an example of where like a simpler intervention, one of the things that we're seeing more often amongst marginalized populations is they might get referred for opioid, or we're seeing a lot of patients who are coming in for opioid use disorder who are getting sent to inpatient detox because they'll accept, like these certain programs will accept them, and they're kind of like short detox, and it's a lower standard of care as opposed to initiating and continuing treatment. And so the strategy the way that I think about this is medicalizing social determinants, and doing this, emergency medicine, we manage so many different things, and we try to keep things simple and through algorithms so we don't have to, so that we can get them done and have processes. So we just think about our ABCs of trauma, when you have a STEMI protocol or stroke protocol, there's structure, there's clarity, there's process. And so you develop resources in advance from the subject matter experts and then have them so that they can be carried out at 24 hours a day. And so if there's somebody during the day that knows how to get somebody in identification and there's a process, have that mapped out so that somebody who doesn't have that expertise at 2 o'clock in the morning can do it. And my mnemonic that I use that for my current one of my current studies is trying to address so my mnemonic is ET phone home ID insurance. So E is for eating or food insecurity, transportation, T is for transportation mobility, phone is access to a phone, homes, housing needs, identification, so if you're prescribing buprenorphine, you need to have an identification to pick it up, and so helping with an identification, and insurance, whether somebody has it, if they have their information, and how we can help them with that. So they're picking like a select number that are feasible to address is what I would recommend. And I just wanted to thank you, appreciate your participation and being here so early in the morning. And our emails are here. I'm going to say them out loud because our slides on the app are the wrong version. And so it's ryan.mccormack, MCCORMACK at nyulangone.org, or ryan214@gmail, and Kathryn Hawk, spelled KATHRYN .Hawk, like the bird, at yale.edu. And then we also have our references and of the things that we talked about, as well as some others. Thanks. Thank you.
Do we have questions?
Oh.
I mean, we're kind of out of time, but I would.
Are we out of time?
We have a
Are
couple
you the
minutes.
next presenters? Okay.
Maybe just
Okay.
Okay.
a quick question about the free phones and phone plan. I'm just wondering how that worked, what the details were, like how long did you give them of the phone plan? What happened after that? Did they lose a number, et
Yeah,
cetera?
that's an interesting, there are some nuances that it actually took over a year for us to get approval to do that because we were using them for contact. So you'll need to look into it. But what we ended up doing is we used a company, like a cheaper company, where we could get refurbished phones. And then we have 30-day follow-up that starts on, the earliest can be 30 days. So we do a 2-month plan. And then, but it's not that, the process takes some time. So you have to set up an email account if they don't have one so that you can activate the phone. There are phones available for people who, like the Lifeline, I think it's Lifeline, people call them Obama phones. And they are accessible, but what we experienced when we started doing this was during the pandemic, and you couldn't get them in person, you had to have an identification, and it took 2 weeks, they would be delivered in like 2 weeks. Some places have them like right outside, so we could be like, you can go to 14th Street and get it, but we couldn't enroll somebody unless they had a phone. But one of the challenges to consider with that, if you're doing research where you're collecting sensitive data on the phone, you may not be able to use one of those kind of inexpensive phones. So that was the barrier that took us about a year, is that our IRB wanted us to use a specific phone that was on our thing that was like, would have been almost $1,000 because they required a year-long plan, and it was just silly. But it's, so whether you direct people to resources or provide that, was our path.
We didn't ask for the back, like this is your phone.
Yeah, so some will do that, and there are some studies that our experience is that a lot of people lose them, but a lot of people don't, and so there's a lot of, when we kind of bring this up to people, like, oh, there's no point because people will lose them or sell them, and it kind of, a lot of that will bring up stigma and prejudice, but it is it's definitely not always the case, and it's also something that has been helpful in trust building. Just like I mentioned, and I have a paper called Voices of, this isn't the right language that we use anymore, but Voices of Homeless Alcoholics at Bellevue Hospital, where we did qualitative interviews among patients with alcohol use disorder and kind of really uncovered some of the ways of building trust and identifying what the patient's needs are and trying to address them. So I think that incorporating those into your studies is something that I definitely try to do, putting money in for like food and things, like, well, there's certain things you're not allowed to do, but trust building. So in the interest of time, I'm going to stop. You can also call me or ping me by my cell phone, which is 646-812-0218. Thanks.